right now, your immune system is, well, it's defending you from millions of microscopic threats.
Oh, absolutely. Constantly.
Right. Like bacteria on your keyboard, spores in the air, maybe a virus lingering on a door handle you just touched. It is this elite, highly calibrated defense network that is quite literally designed to keep you alive. But for over 500,000 people in the United States alone, that exact same elite defense system has fundamentally malfunctioned.
It really has.
It has turned everyday, completely innocuous things. I mean, things like taking a warm shower, wearing a snug belt, or, simply toweling off after a swim into a source of absolute physical torment.
Yeah, which is terrifying when you think about it.
It really is. So we are undertaking a massive deep dive today into a condition that completely hijacks the human body, and that is chronic urticaria.
And it's a condition that is terribly misunderstood.
Yeah.
It's often dismissively waved away as, just hives, as if it were a minor temporary nuisance. But when you actually look at the clinical reality, you see a disease that carries this profound, hidden global burden.
Right.
Understanding our skin, particularly when it behaves this erratically and aggressively, it provides a striking window into the sheer complexities and, frankly, the vulnerabilities of the human immune system.
And to really decode what is happening to all these people, we are pulling from a massive stack of research today.
We definitely are.
We have two primary, incredibly dense sources guiding our conversation. First, a staggering 2019 global systematic review and meta-analysis, and this was published in the journal Allergy.
Yes.
And when I say staggering, I mean the sheer volume of data is hard to wrap your head around. They analyzed data spanning over 86 million participants worldwide.
Which is an epidemiological goldmine.
86 million.
Right. Capturing a data pool of that magnitude for a dermatological condition is exceedingly rare. It really allows us to step back and look at the footprint of this disease across the entire human population.
Exactly. And our second source brings us right down into the exam room. It's a highly detailed 2022 clinical review article from the New England Journal of Medicine, or NEJM.
A fantastic paper.
Truly. So between the global epidemiology in the first paper and the cellular level clinical pathways in the second, we have a complete map of this condition.
We do.
But before we get to the 86 million people or, the cutting edge treatments, we really have to zoom in. We need to go microscopic.
Start at the foundation.
Right. What exactly is happening under the skin? Let's define the baseline, because almost everyone has had a random hive at some point in their life. You eat a weird shellfish, you get a bumpy rash, it goes away. What separates that from what we are talking about today?
So the dividing line in the medical literature is 6 weeks.
Okay, 6 weeks.
Right. If you have an episode of hives, which physicians refer to as wheals, by the way, and it fully resolves in less than 6 weeks, that is classified as acute urticaria.
Okay.
That is the classic allergic reaction. The body encounters a transient trigger, perhaps, a new medication like an antibiotic, a specific food allergen, or even a passing viral infection.
Like a cold or something.
Exactly. The immune system reacts, the trigger is processed and cleared from your system, and the body returns to its baseline state.
But if you wake up on day 43 and your skin is still breaking out?
Then you cross the diagnostic threshold into chronic urticaria, or CU.
Wow.
This means these wheals are continuously or intermittently appearing for at least 6 weeks, and honestly, often for much, much longer. And the biological mechanism driving both the acute and the chronic forms begins with a specific type of immune cell called the mast cell.
Okay, let's unpack this. So mast cells are basically like an overly sensitive building security system.
That's a good way to put it.
If they're working normally, they catch a burglar. A parasite, a dangerous toxin. But in chronic urticaria, it's like a leaf blows against the front window and the system completely panics.
Right.
It trips the alarm and releases a massive flood of chemical foam, the histamine, that causes all this collateral damage, all the swelling and the redness, when there was no actual threat at all.
That is an excellent framework for understanding the pathology. Mast cells are stationed right at the boundaries of your body, so in the skin, the lining of the lungs, the gut.
They're the border patrol.
They are the sentinels, yes. And when they panic, as you put it, the physical process is called degranulation.
Degranulation is called.
The mast cell is essentially packed full of tiny toxic granules. When triggered, the cell membrane opens up and violently dumps these granules into the surrounding tissue. And histamine is the most famous chemical in that payload.
And histamine is what makes you want to just claw your skin off.
Oh, yes. Histamine is the major mediator for that intense burning itch, which in clinical terms is called pruritus.
Pruritus, got it.
It directly stimulates the nerve endings in your skin. At the same time, it binds to receptors on your local blood vessels, causing them to rapidly dilate.
No.
That sudden widening of the blood vessels brings a rush of blood to the surface, creating the erythema, the bright red halo or flare you see surrounding the raised bump.
But the NEJM paper makes it clear that histamine is just the first responder, right? I mean, It's an acting alone. The mast cell is actually releasing an entire cocktail of chemicals.
Yes, what's fascinating here is that it releases a highly complex inflammatory cascade. We are talking about cysteinoleucotrienes, prostaglandins, and platelet-activating factors.
Whoa, okay, let's actually unpack that jargon, because prostaglandins and leukotrienes sound like something out of an advanced chemistry textbook.
They do, yes.
What are those backup dancers actually doing to the skin?
Think of it this way. While histamine is causing the immediate alarm, the redness and the nerve irritation, these other chemicals are fundamentally altering the microscopic architecture of your blood vessels.
Changing the architecture.
Well, leukotrienes, for instance, are incredibly potent at increasing vascular permeability. They signal the endothelial cells, the cells that line the walls of your tiny veins, to physically pull apart from one another.
Wait, really? They're essentially opening up microscopic trapdoors in the veins.
Precisely. And when those tight junctions open, actual blood plasma, the fluid component of your blood, physically leaks out of the vascular system and pools into the surrounding skin tissue.
Oh, that sounds awful.
It is. That trapped pocket of leaked fluid is what physically builds the raised hard welt, the wheal, that you can feel on the surface of the skin.
Wow.
It also draws in a predominantly lymphocytic infiltrate, meaning white blood cells migrate into the tissue to investigate the false alarm, which just perpetuates the inflammation.
And the physical behavior of these wheals is fascinating.
Yeah.
The sources note they're very specific. I mean, they can be tiny, just a few millimeters, or they can merge together to form massive plaques several centimeters across.
Yes, they can be quite large.
But the defining diagnostic characteristic is how long they last. An individual hive resolves in under 24 hours, and it leaves no trace, no bruise, no scar.
That transient nature is a vital clue for a physician. The disease itself might persist for years, but the individual lesions are ephemeral.
It's ephemeral, right?
The plasma leaks out, the welt rises, and then over the next 12 to 24 hours, the fluid is reabsorbed by the lymphatic system, and the skin returns to looking completely normal, only for a new welt to erupt on a different part of the body.
It's like a bizarre game of whack-a-mole.
It really is. If a patient says a single welt has stayed in the exact same spot for 3 days, or if it leaves a bruise when it fades, the physician immediately knows they're not dealing with standard urticaria.
Good to know. And we also have to talk about angioedema, because the wheals are only part of the story. The NEJM review highlights that 2/3 of CU patients experience deeper swelling alongside the surface hives.
2/3, yes. Angioedema operates on the exact same biological mechanism, mast cell degranulation and fluid leakage. But it happens in the deeper layers of the dermis and the subcutaneous tissues.
Deeper down.
Because the tissue architecture is looser down there, the fluid spreads out more. It doesn't present as a defined, itchy bump. It manifests as profound, diffuse swelling.
And it usually targets areas where the skin is quite distensible, right? Like the lips, the eyelids, the extremities, or even the genitals. The paper noted it often feels painful or tight rather than itchy.
Exactly. The visual of your own face, unpredictably distorting and swelling up, it is deeply distressing for the patient. It alters their appearance drastically and can take up to 72 hours to resolve.
Which brings us back to that crucial 6-week timeline. We talked about how an acute reaction clears up. But biologically, why is 6 weeks the magic number where doctors say, okay, this is a chronic disease now? What is happening at day 42?
Well, it is less about a biological switch flipping on day 42 and more about the timeline of the human immune system clearing out an external trigger.
Oh, I see.
Let's say you catch a bizarre virus that triggers hives, or you take a medication that has a long half-life in your body. It might take your liver and kidneys a few weeks to completely break down and excrete every last molecule of that trigger.
Sure. Processing time.
But by 6 weeks, those transient external factors are virtually guaranteed to be gone from your system.
So if the hives are still happening at week 7, it means the call is coming from inside the house.
That is the grim realization. Yes, the immune system is no longer reacting to an external threat. The system itself has become fundamentally unstable. The mast cells have lowered their threshold for activation so far that they are essentially firing off spontaneously.
Man, that transition from I must have eaten something weird to my immune system is fundamentally misfiring is a heavy psychological burden.
Incredibly heavy.
Which naturally leads us to ask how many people are walking around with this malfunctioning security system. If we pull back from the cellular level and look at the globe, what do we see? This is where that 2019 allergy meta-analysis provides some incredible insights.
Yes, and to appreciate the findings, we really need to appreciate the methodology. A meta-analysis of this scale is a massive undertaking.
86 million people.
Right. The researchers didn't just conduct one study. They scoured the global medical literature, identifying 18 highly rigorous population-based studies. They ultimately integrated 11 of those into the core meta-analysis, encompassing over 86.6 million participants.
Which gives us a level of statistical power you rarely see. And the numbers they derive from that massive pool are striking.
They are.
The overall global point prevalence, which means the percentage of people who have active chronic urticaria right at any given moment, is 2.7%. And the lifetime prevalence, the statistical probability that you will develop this condition at some point in your life, is 1.4%.
And when you apply that 1.4% to the global population, you start to see the immense scale of the healthcare burden.
Right. We are talking about tens of millions of people globally. But as I was reading through the data tables, what stood out wasn't just the raw numbers, but the massive regional disparities. The geography of this disease is completely uneven.
The geographical variance is actually one of the most heavily debated topics in urticaria research right now.
So let's look at it. The point prevalence in Latin America is incredibly high, sitting at 1.5%. Asia's right behind it at 1.4%.
Mm-hmm.
But then you look at Europe, and the prevalence drops down to 0.5%. And Northern America, so the U.S. and Canada, is all the way down at an astonishingly low 0.1%.
A huge drop.
Yeah. Here's where it gets really interesting. Northern America is at 0.1%, but Latin America is at 1.5%. Is the disease actually less common in the U.S.? Or are the studies in North America just missing the inducible cases, since the text notes those studies only looked at spontaneous urticaria?
You've hit on the exact crux of the epidemiological problem. The short answer is we are almost certainly undercounting cases in North America due to how the clinical studies were designed.
Oh.
In the meta-analysis, the researchers reported a statistical metric called the I-squared value, which measures heterogeneity.
What does that mean in plain English?
It basically measures how different the underlying studies are from one another. The I-squared value for this data was 100%.
Wait, 100% heterogeneity means the studies had almost nothing in common methodologically.
Correct. It means the researchers were forced to compare apples to oranges on a global scale. We currently lack a standardized, universally accepted diagnostic questionnaire for chronic urticaria.
That's surprising.
It is. If you study asthma epidemiology, scientists worldwide use something called the ISAC tool. It is a standardized set of criteria that allows a researcher in Tokyo to perfectly compare their data with a researcher in Toronto.
But we don't have that for chronic hives.
No, we don't have an ISAC equivalent for CU. The North American studies relied heavily on specific billing codes and electronic health records that selectively filtered out patients whose hives were triggered by specific physical stimuli.
So the 0.1% isn't that North Americans don't get chronic hives. It's that our healthcare tracking system artificially excluded a massive chunk of the patient population.
Undoubtedly. However, the researchers cautioned against dismissing the geographic differences entirely. While methodology explains part of the gap, the authors of the Mexican study included in the review proposed a fascinating hypothesis. They suggested that the distinct climatic factors in certain Latin American regions, specific combinations of ambient temperature, humidity, and endemic infectious agents might genuinely create an environment that pushes a susceptible immune system over the edge into chronic mast cell activation.
Wow, that intersection of environment and biology is so complex. And the biology gets even more intriguing when you look at who is getting the disease within those populations.
Right.
The demographic split based on sex and age is a massive clue to what is driving the condition.
The gender distribution is perhaps the most revealing data point in the entire meta-analysis regarding the underlying pathophysiology.
Right, because globally, adult women are significantly more affected than adult men. The point prevalence for women is 1.3%, whereas for men it's only 0.8%. So nearly twice as many adult women are dealing with this. But then, the researchers looked at the pediatric data. They isolated children under 15 years old, and that dramatic sex difference just vanishes. Little girls and little boys develop chronic urticaria at the exact same rate, around 1.0 to 1.1%.
Which is a profound finding. If a prepubescent boy and girl have the exact same biological risk of their mast cells malfunctioning, but an adult woman is nearly twice as likely to develop the condition as an adult man, the primary variable introduced between those two life stages is sex-specific hormones.
The transition through puberty fundamentally alters the immune system's baseline.
We observe this pattern across several autoimmune and immune-mediated conditions. Lupus, rheumatoid arthritis, certain severe phenotypes of asthma, they all show a striking female predominance that often emerges post-puberty.
So estrogen is playing a role.
The prevailing theory in urticaria research is that fluctuations in estrogen and progesterone actively lower the activation threshold of mast cells. Interestingly, many female patients report a distinct worsening of their hives in the days immediately preceding their menstrual cycle, directly correlating with a drop in progesterone and an estrogen shift.
It's incredible to think that your endocrine system, your hormones, can directly talk to your immune system and essentially tell your skin to be more reactive.
It is a deeply interconnected system.
And adding one more alarming layer to this global picture is the time trend. The studies that track prevalence rates across multiple decades all pointed the arrow firmly up. Chronic urticaria is becoming more common globally.
It is an active, growing public health burden. And determining whether that increase is due to rising environmental stressors, the proliferation of modern synthetic chemicals, widespread changes in the human microbiome, or simply better diagnostic awareness is a monumental task for future researchers.
But I want to pull back from the global map for a second. When you look at 86 million data points and global percentages, it's easy to just see them as numbers on a spreadsheet.
They're very easy.
You hear 1.4% lifetime prevalence, and you think, okay, a rare, somewhat annoying skin rash. But the NEJM review brought the actual daily human cost of this disease into stark, almost brutal focus.
The impairment to a patient's quality of life is arguably the most critical aspect of this entire deep dive. If we don't understand the suffering, we can't understand why the treatment protocols are so aggressive.
The NEJM data revealed a clinical comparison that genuinely made me stop reading. They utilized validated clinical tools to measure the burden of disease, and they found that the impairment in quality of life for a patient with severe chronic urticaria is statistically similar to that of a patient with coronary artery disease who is currently awaiting coronary artery bypass grafting.
They are comparing the psychological and physical burden of a skin condition to the experience of a patient waiting for open heart surgery.
So what does this all mean? We often treat skin conditions as cosmetic annoyances. But the data says waiting for a random hive attack is as psychologically taxing as waiting for open heart surgery. That unpredictability must be mental torture.
The comparison is shocking, but neurologically and psychologically, it is entirely sound. The devastation stems from two primary factors: intense sleep deprivation and the absolute loss of bodily autonomy.
Let's talk about the sleep disruption, because the paper emphasizes how severe the pruritus, the itching, truly is.
Histamine-driven itch is not like a mosquito bite. It is a deep, agonizing sensation. Furthermore, our body's natural circadian rhythm causes our core body temperature to drop slightly at night, and our endogenous cortisol levels, our natural anti-inflammatory hormone, are at their lowest in the late evening.
So the defenses are down.
Exactly. This means the hives often flare most aggressively right when the patient is trying to sleep. The pruritus utterly destroys normal sleep architecture. Patients are trapped in a cycle of micro-weakenings, scratching until they bleed. They wake up fundamentally exhausted day after day, week after week.
And when you are chronically sleep deprived, every other aspect of your life begins to fracture. Your cognitive function drops. Your emotional regulation is shot.
And then you add the psychological horror of unpredictability. Remember, the majority of chronic urticaria cases are classified as spontaneous. There is no identifiable exogenous cause.
No obvious trigger.
Right. The patient didn't pet a strange dog, they didn't eat a new food, they didn't switch laundry detergents. Their body is simply attacking itself without logic or reason. The visible welts and the facial swelling of angioedema make them feel socially stigmatized. They begin to isolate.
They just hide.
Yes. They cancel plans, they perform poorly at work because they're distracted by the physical discomfort and the mental fog of exhaustion. If we connect this to the bigger picture, healthcare systems face massive costs from frequent visits and loss of work productivity, making this an economic issue as well as a medical one.
It's no surprise then that the paper noted a significantly higher rate of coexisting psychiatric conditions in these patients compared to the general population.
Anxiety, depression, and severe somatoform disorders are rampant in this patient population. The constant hypervigilance, waiting for the next flare, constantly scanning your body for the first sign of an itch, rewires the nervous system into a chronic state of fight or flight.
It's a disease that holds your daily life hostage. But while the spontaneous form has no known cause, which is terrifying in its own right, the inducible form of chronic urticaria is triggered by highly specific, sometimes completely bizarre physical stimuli.
Very bizarre.
Let's explore the strange ways the physical environment can seemingly wage war on the skin. The NEJM provided a detailed table of these inducible urticaria syndromes, and frankly, some of them read like a biological curse.
They represent some of the most remarkable and perplexing manifestations of immune hypersensitivity in all of medicine. The most common inducible form is called symptomatic dermatographia,
Which translates from Greek directly as skin writing.
It does. It affects up to 5% of the general population, though many cases are mild enough that the individual never seeks medical treatment. In dermatographia, the mast cells in the skin degranulate in direct response to shearing forces, mechanical pressure, rubbing, or scratching.
So friction.
Exactly. If you take a firm object, like a smooth wooden tongue blade, and apply moderate pressure while stroking the skin, within 1 to 3 minutes, a perfectly raised, fiercely itchy red wheal will appear, exactly tracing the line you drew.
Think about the shirt you're wearing right now. The pressure of the fabric on your shoulders, the friction of the collar against your neck. For someone with severe dermatographia, that completely normal friction is interpreted by their mast cells as a full-blown traumatic injury.
That's exactly how the body treats it.
If someone has dermatographia, does that mean simply toweling off too hard after a shower could cover them in hives? How do you live a normal life when the trigger is touch?
Yes, and that is a common clinical presentation. It requires immense behavioral adaptation from the patient. You have to meticulously police your physical interaction with the world. You must wear incredibly loose-fitting, soft clothing. If you feel a normal itch from a loose hair, you cannot scratch it, because scratching will instantly trigger a massive wheal.
That sounds exhausting.
You have to pat yourself dry incredibly gently. Your physical boundaries become a minefield.
And dermatographia is just the most common one. Then there is cholinergic urticaria.
This form accounts for roughly 5% of all chronic urticaria cases, and the trigger here is a rise in core body temperature.
So if you decide to take a hot bath to relax, or you go for a run and start sweating, or even if you just experience a sudden intense emotion like getting angry or deeply embarrassed that raises your body temperature.
Any of those factors can trigger it. The nervous system senses the internal heat and releases a neurotransmitter called acetylcholine to stimulate the sweat glands. In these patients, the mast cells abnormally cross-react to that signal.
The wiring is crossed.
The body responds by breaking out in very specific, pinpoint tiny punctate wheals, which are usually surrounded by massive, disproportionately large red flares. In the clinic, we diagnose this by literally having the patient perform a supervised exercise test, or sometimes by partial immersion in 42 degrees Celsius water to deliberately provoke the reaction.
We are deliberately dunking people in hot water to see if their skin rebels.
We have to observe the reaction.
But if heat is weird, the next one is genuinely difficult to comprehend. Aquagenic urticaria, triggered by hot or cold water, the literal physical contact of water touching the skin.
It is exceptionally rare, and the pathogenesis, the biological mechanism, remains a source of deep debate. As humans, we are fundamentally water-based organisms. We are mostly made of water. The concept of being allergic to water seems biologically paradoxical.
Right. How does a cell that floats in fluid react to water?
The leading hypothesis is that the immune system is not actually reacting to the water molecule itself. Instead, the theory suggests that when water interacts with the stratum corneum, the dead outermost layer of the skin, or with the natural sebum oils that our sebaceous glands produce, that chemical interaction creates a novel, toxic compound.
Now,
That newly created compound is then absorbed into the deeper living layers of the skin, where it acts as a potent antigen, activating the mast cells.
so the water acts as a catalyst, creating a poison out of your own natural skin oils.
There's something incredibly unnerving about that. The idea that interacting with the very substance that keeps us alive could trigger an autoimmune attack feels like a biological betrayal.
It's deeply unsettling for the patients, yes.
What else is on this list of triggers?
We also see delayed pressure urticaria. This is where sustained vertical pressure, like wearing a tight belt, the strap of a heavy backpack, or sitting on a hard wooden chair for an extended period causes deep, often painful swelling. But the clinical twist, and what makes it so baffling for patients, is the timeline.
Right, the delay. The swelling doesn't happen immediately. It appears 2 to 12 hours after the pressure is applied.
So you wear a heavy backpack on your morning commute, take it off at 9 a.m., feel totally fine all day, and then while you're eating dinner at 7 p.m., your shoulders swell up into painful welts. Good luck connecting those dots without a doctor.
Exactly. It makes identifying the trigger incredibly elusive. Patients often assume it was something they ate for dinner, entirely forgetting the backpack from 10 hours prior.
Makes sense.
We also have cold urticaria, triggered by handling ice, walking in a cold wind, or swimming in a cold lake. And solar urticaria, where specific wavelengths of UV or even visible sunlight cause the hives. And we have exercise-induced urticaria.
And the exercise one has a fascinating subcategory mentioned in the text, the augmentation factor.
This is a critical nuance. In some patients, exercising alone is perfectly fine. Their mast cells stay quiet. But if they exercise after eating a very specific food like wheat or celery, even if they aren't strictly allergic to that food while resting or after taking a non-steroidal anti-inflammatory drug, an NSAID like ibuprofen, the combination of the two factors triggers a massive urticarial eruption.
It requires a perfect storm. The NSAID primes the pump, and the exercise lights the match.
Yes, beautifully put.
The testing for all these specific triggers in the clinic sounds almost medieval. You mentioned the hot water immersion. The text also talked about hanging a 7-kilogram weight over a patient's shoulder for 15 minutes and then waiting hours to test for delayed pressure urticaria. Or applying vibrating vortex mixer, a laboratory tool, to the forearm for several minutes to test for vibratory urticaria.
It may sound archaic, but these are highly standardized, carefully calibrated provocation tests. To confirm the diagnosis, the physician must replicate the exact physical stimulus in a controlled environment. But when you step back and look at this entire list, water, temperature, vibration, sustained pressure, sunlight, it highlights a profound evolutionary oddity.
Exactly. Why would the human immune system, which spent millions of years evolving complex mechanisms to identify and destroy highly specific, deadly parasites and mutating bacteria, suddenly decide that gravity or a cool breeze or your own sweat is a mortal threat?
It represents a catastrophic misdirection of an ancient defense mechanism. The mast cell is designed to be highly reactive. It is supposed to respond to the venom of a wasp sting or the localized damage of a bacterial invasion. In patients with inducible urticaria, the cellular receptors on these mast cells have become structurally unstable, or the intracellular signaling pathways have become hypersensitized to basic physical forces.
The forces themselves trigger it.
Right. The physical energy itself, kinetic energy from vibration or thermal energy from a cold wind, is somehow enough to destabilize the cell membrane and trigger the release of histamine. The sentinel is firing its weapon at shadows.
Okay, so imagine you are the patient. Your body's reacting to sunlight or the pressure of your clothes, or you have this spontaneous form and you are waking up covered in welts for no reason at all. You are exhausted, you are terrified. Naturally, you march into your doctor's office, roll up your sleeve, and demand every blood test known to modern science. You want them to find the hidden parasite. You want them to check your thyroid, your liver, look for a secret viral infection, because it feels like there has to be an underlying fixable reason. But surprisingly, the clinical guidelines outlined in the NEJM say the exact opposite.
This is perhaps one of the most counterintuitive and frustrating aspects of managing chronic urticaria, both for the patient and often for the physician.
Why is that?
Historically, there was a massive urge in the medical community to test for associated systemic disorders. If a patient presented with chronic hives, we would run sweeping diagnostic panels. We would look for hepatitis B and C, Epstein-Barr virus. We'd check for Helicobacter pylori bacteria in the gut. We'd test for thyroid disease, lupus, rheumatoid arthritis, chronic focal infections in the teeth or sinuses. The list was endless.
Because the doctor wants to be a hero. They want to find the smoking gun and cure you.
Precisely. The instinct to cure is powerful, but the modern choosing wisely guidelines, which are established by major medical academies to prevent unnecessary, wasteful, and potentially harmful medical procedures, actively recommend against routine and extensive laboratory testing for chronic urticaria. It has been conclusively proven to not be cost-effective, and far more importantly, it doesn't actually improve patient outcomes.
The NEJM paper had the data to back this up, and it was a stunning statistic. They cited a retrospective review of 1,872 laboratory tests that were ordered across 356 cases of chronic urticaria. Out of nearly 2,000 tests, guess how many led to a change in management that actually improved the patient's hives? One. Just one single test, an abnormal thyroid function test that led to a specific hormone adjustment.
That statistic should be sobering for any physician who relies too heavily on lab work. Out of those 1,872 tests, 319 actually came back labeled abnormal. But almost every single one of those was a false positive, a transient elevation, or an incidental finding that had absolutely nothing to do with the pathogenesis of the patient's urticaria.
Wait, if I go to the doctor with chronic hives, you're telling me they shouldn't run a massive blood panel? Isn't that counterintuitive? It feels like refusing to check the engine light on your car.
This raises an important question about value in medicine. We have a cultural assumption that medical testing is a neutral good. We believe that more information is always inherently better. But in the context of chronic spontaneous urticaria, widespread untargeted testing causes active, measurable harm to the patient.
How does a blood test cause harm? It's just a needle prick.
The physical draw isn't the harm. The cascade of consequences from the results is the harm. When those 319 tests came back abnormal, it didn't solve the patient's hives. Instead, it triggered a massive secondary wave of anxiety. It led to repeat blood draws. It forced unnecessary referrals to rheumatologists, endocrinologists, or infectious disease specialists.
Oh, I see.
It subjected the patient to weeks or months of waiting and terrified worrying that they had a hidden lymphoma or a severe systemic autoimmune disease. And ultimately, it was all for an incidental blip on a lab report that had zero correlation to their skin. In medicine, when the pre-test probability of finding a specific disease is extremely low, running the test mostly just generates false positives.
So what is the doctor supposed to do? If they aren't drawing vials of blood, how do they figure out what's wrong?
The physician has to return to the foundational skills of medicine. A comprehensive, intensely detailed clinical history and a thorough physical examination are vastly more powerful diagnostic tools than a scattershot blood panel. The doctor acts as a detective.
Just talking to the patient.
Yes, sitting down and talking. They meticulously map out the timeline of the hives, the exact physical characteristics of the wheals, the presence or absence of angioedema, any correlations with physical triggers, medications, or travel. They are listening for specific red flags that might suggest the patient doesn't have urticaria at all, but rather a more dangerous mimicker, like cutaneous vasculitis.
You mentioned vasculitis earlier. If a patient comes in with red bumps, how does the doctor know it's vasculitis and not just a severe case of chronic hives?
Cutaneous vasculitis is a fundamentally different pathological process. In urticaria, as we discussed, the blood vessel temporarily opens its junctions, fluid leaks out, and then the vessel closes and goes back to normal. In vasculitis, there is active destructive inflammation of the blood vessel wall itself. The vessel is being damaged.
Okay.
And the clues are entirely in the physical presentation and the patient's history. A normal urticaria wheal lasts less than 24 hours and is intensely, maddeningly itchy. Vasculitic lesions last much longer, often days. Furthermore, because the blood vessel is actually sustaining structural damage and bleeding microscopically into the skin, the lesions often feel painful or burning rather than itchy, and crucially, they leave a residual bruise, a purpuric discoloration when they finally fade.
So if the doctor hears that history pain, instead of itch, lasting 3 days, leaving a bruise, then they investigate.
Exactly. If the clinical history points to vasculitis, then the doctor orders targeted tests, specifically a skin biopsy, to look at the blood vessels under a microscope. But if the history is classic, transient, itchy, chronic urticaria, the broad blood panels are put away.
Okay, so we've established a diagnosis, we've skipped the unnecessary blood tests and avoided the false positive anxiety spiral. But we still have a patient sitting in the exam room, utterly exhausted, scratching their arms raw, desperate for relief. If we aren't looking for a hidden cure, how do we actually help them? We transition into what the NEJM outlines as the stepped care treatment ladder. It's a highly structured, rigid protocol.
It is a profoundly pragmatic, purely evidence-based approach. We must be honest with the patient currently. We cannot cure the underlying cellular hyperreactivity. Our entire pharmacological goal is to suppress the mechanism to block the histamine and the inflammatory cascade so completely that the patient's quality of life is fully restored. We want them to live as if they don't have the disease while we wait for the immune system to eventually reset itself.
Step 1 is the foundation. Second-generation H1 antihistamines. These are your standard, modern, over-the-counter allergy medications, things like cetirizine, loratadine, or fexofenadine. But the NEJM points out a crucial detail that most patients get wrong. You have to take them regularly, on a strict daily schedule, not just as needed.
That is the single most common cause of treatment failure at step 1. Patients are used to treating acute issues. They get a headache, they take a painkiller, so they assume that when they feel an itch, they should take an antihistamine.
Which makes logical sense to a normal person.
It does, but by the time you feel the intense pruritus, the mast cell has already degranulated. The histamine is already flooding your dermal tissue and actively binding to the H1 receptors on your nerves and blood vessels. If you take the pill then, the medication is playing catch-up. It can't pry the histamine off the receptor, it just has to wait for the histamine to degrade.
You're trying to close the barn door after the horses are out.
Precisely. To effectively control chronic urticaria, you must achieve continuous competitive blockade of those histamine receptors. You take the medication every single day, building up a steady concentration in your bloodstream. You are essentially painting a chemical shield over the receptors.
I love that visual.
That way, when the mast cell inevitably degranulates, the released histamine floats through the tissue, finds no open receptors to dock with, and is harmlessly metabolized.
But the clinical data shows that step 1, taking the normal FDA-approved daily dose, only works for less than 50% of patients. More than half the people are still breaking out, still suffering. So the doctor has to move them to step 2. And step 2, honestly, sounds wild when you first read it.
It can sound extreme, yes.
The protocol authorizes doctors to prescribe dose escalation up to 4 times the standard FDA-approved dose of these second-generation antihistamines. Okay, step 2 is wild. 4 times the normal dose. That's like realizing one garden hose isn't putting out the house fire, so you just grab 3 more hoses rather than switching to a fire extinguisher. Is that safe?
It is safe and recommended by global guidelines. Your analogy of the hoses is apt. We are simply trying to drown the fire in a higher volume of medication, but to understand why it is safe to push the dose that high, we have to look at the elegant pharmacology of these specific drugs. The second-generation antihistamines were specifically engineered by pharmacologists to fix a dangerous flaw inherent in the original first-generation drugs.
When you say first generation, you mean the older drugs like a diphenhydramine, which is Benadryl or hydroxyzine.
Yes. Those older molecules are highly lipophilic, meaning they dissolve easily in fats. Because of that chemical structure, they easily and rapidly cross the blood-brain barrier. They don't just stay in your skin, they flood into your central nervous system.
Which causes the drowsiness.
More than just drowsiness. In the brain, histamine is an essential neurotransmitter that promotes wakefulness and alertness. When a first-generation antihistamine enters the brain and blocks those central receptors, it causes profound, heavy sedation, cognitive impairment, and delayed reaction times. In older adults, they're incredibly dangerous, causing severe confusion, urinary retention, and a high risk of falls.
Which is why the guidelines explicitly say to avoid using first-generation antihistamines in older populations.
Absolutely. But the second-generation drugs are large, bulky, lipophobic molecules. Their physical size and chemical charge prevent them from easily crossing the blood-brain barrier.
So they get trapped in the peripheral system, they stay out in the body, right in the skin where the hives are happening.
Exactly. And because they are functionally locked out of the brain, the risk of central nervous system toxicity is incredibly low. We can push the peripheral dose incredibly high, 2, 3, or 4 times the standard dose, massively saturating the H1 receptors in the skin without turning the patient into a somnolent zombie.
That's a huge relief.
It provides highly effective symptom control for a large cohort of patients who failed step 1. In step 2, physicians might also try adding adjunct therapies. They might prescribe H2 antihistamines.
Wait, H2 blockers. Are those medications like famotidine, which are typically used to treat stomach acid and heartburn?
Yes. While H1 receptors are the primary drivers of the itch and redness, the blood vessels in the skin also have a smaller population of H2 receptors. By blocking both H1 and H2 pathways simultaneously, you can sometimes achieve a tighter seal on the vascular permeability. Doctors might also prescribe anti-leukotriene medications, like montelukast, to block those specific backup dancer chemicals, the leukotrienes that we discussed earlier, which cause the deep tissue swelling.
The review also issues a massive, bolded warning about what not to do when patients are struggling in step 2. When a patient is covered in hives and desperate, doctors are heavily tempted to prescribe systemic glucocorticoids, steroids like prednisone, to quickly knock out the inflammation. And while a short burst of steroids for 3 to 5 days might cool off a severe acute flare-up, the clinical guidelines explicitly demand that doctors avoid using steroids long-term.
The risk-to-benefit ratio for chronic systemic steroids is completely unacceptable for this condition. Yes, steroids will clear the hives beautifully. They are powerful global immunosuppressants, but the cumulative side effects of chronic steroid use are devastating.
Like what?
We are talking about irreversible bone density loss leading to osteoporosis, steroid-induced diabetes, severe hypertension, adrenal gland suppression, cataracts, and profound psychiatric mood shifts.
You're basically trading a skin condition for organ failure.
It is a terrible trade, and the most tragic part for the patient is the rebound effect. The moment you attempt to taper the patient off the systemic steroids, the immune system, which has been artificially suppressed, roars back to life. The hives almost always rebound, frequently coming back far worse and more aggressive than they were before the steroids were started.
So long-term steroids are entirely off the table. The paper also mentioned a few lifestyle and dietary recommendations for patients in these early steps. They advise patients to avoid NSAIDs, like aspirin or ibuprofen, because the data shows that in 20 to 30% of patients, NSAIDs actively exacerbate the hives. If you have a headache, use acetaminophen instead.
Correct.
Avoid heavy alcohol use and try to manage stress, as both lower the threshold for mast cell degranulation. But what I found fascinating was the firm stance on diet. The guidelines state that empirical elimination diets are actively not recommended. Don't go on a grueling, gluten-free, dairy-free, sugar-free, low histamine diet hoping to magically cure your spontaneous hives, because the statistical data says it almost never works.
It is incredibly common for patients to obsess over their diet, largely because eating is one of the few variables they can control. But for chronic spontaneous urticaria, food is almost never the hidden culprit. Putting a patient on a severe restriction diet just adds massive psychosocial stress and potential nutritional deficits to someone who is already suffering a profound impairment in their quality of life.
But what happens when the 4 hoses still aren't enough? What if a patient is taking quadruple the dose of antihistamines, taking an H2 blocker, avoiding NSAIDs, doing everything perfectly, and they're still waking up with massive welts and angioedema? We reach step 3, the heavy artillery, the biologics.
Step 3 represents the pinnacle of modern targeted immunological engineering. When antihistamines fail, we stop trying to block the histamine after the explosion, and we try to stop the explosion from happening in the first place. The primary game-changing agent here is a biologic medication called omalizumab.
This isn't a pill. This is given by a subcutaneous injection every 4 weeks, correct?
Yes. Omalizumab is a recombinant DNA-derived humanized monoclonal antibody. To understand how it works, we have to look at what triggers the mast cell to degranulate in the first place. On the surface of the mast cell are thousands of high-affinity receptors. Sticking out of those receptors are molecules of immunoglobulin E, or IgE.
IgE is essentially the tripwire on the surface of the cell.
Exactly. When an antigen, or in the case of autoimmune urticaria, an autoantibody binds to that IgE tripwire, it pulls the trigger and the mast cell degranulates. Omalizumab is a highly specific, lab-engineered antibody designed to hunt down and bind to free-floating IgE in the blood before it can attach to the mast cell.
It's a heat-seeking missile that destroys the tripwires before they can be installed.
By heavily depleting the free IgE in the blood, omalizumab essentially starves the mast cell. Furthermore, when the mast cell senses that there is no IgE in the environment, it actively downregulates its own surface receptors. It pulls the remaining tripwires back inside the cell. It profoundly disarms the mast cell at a structural level. It is remarkably effective, and it has revolutionized the treatment landscape for patients with severe antihistamine-resistant disease.
And if, by some incredibly unfortunate stroke of biology, even the monoclonal antibody fails to control the disease, the final resort mentioned in the paper is cyclosporine.
Cyclosporine is a highly potent systemic immunosuppressant. It is a calcineurin inhibitor, historically used to suppress the immune system of patients who have received solid organ transplants to prevent their bodies from rejecting the new heart or kidney. It is highly effective at shutting down the T-cell signaling that drives chronic urticaria, but the side effect profile is steep.
It's the absolute last line of defense.
It requires intense, continuous clinical monitoring. The physician must rigorously monitor the patient's renal function, checking their kidneys, and meticulously track their blood pressure, as hypertension is a common and severe side effect.
So we have our step care, we have our daily antihistamine shield, our massive dose escalation, our engineered monoclonal antibodies, and our heavy immunosuppressants. But as a patient sitting in that room going through these steps, there's really only one question that matters. Does this disease ever actually end? We have to look at the prognosis.
It is the most fraught question in the clinic because the answer relies entirely on statistical probabilities rather than guarantees.
The NEJM data offers a mixed bag of hope and frustration. One major prospective study tracked patients and showed that 1 year after starting treatment, 35% of patients were completely symptom-free. They had achieved full clinical remission. Their immune system had seemingly reset. But when you break down that 35%, the split between the types of urticaria is staggering. Spontaneous CU, the terrifying kind, with absolutely no known cause, had a remission rate of 47% at 1 year. Almost half the patients simply got better. But inducible CU, the kind where we know exactly what the trigger is, like cold, heat, or pressure, only had a 16% remission rate. So the spontaneous kind, which has no known cause, is actually 3 times more likely to go into remission than the inducible kind, where we know exactly what the trigger is. That is incredibly frustrating.
I agree. It is a cruel paradox of the disease. We can sit in the clinic and tell a patient with dermatophobia exactly how mechanical friction provokes their hives down to the cellular level. We understand the trigger perfectly, but then we have to look at them and tell them they're statistically likely to suffer from this condition for years, perhaps decades. Meanwhile, the patient whose hives appear seemingly out of the ether, terrifyingly unprompted, has a coin flip chance of their immune system spontaneously curing itself within 12 months.
That has to be incredibly frustrating for researchers. The data also gives us some clues about who is likely to suffer the longest. The review notes that a longer disease duration is strongly linked to 3 specific clinical factors: the presence of angioedema alongside the surface wheals, severe initial symptoms at the time of onset, and crucially, the concurrent presence of autoimmune thyroid disease.
Those factors paint a clinical picture. If a patient presents with massive deep tissue swelling, highly aggressive symptoms, and their immune system is already actively attacking their thyroid gland, it indicates that their body is locked into a deeply entrenched systemic autoimmune state. The dysregulation is profound, and the mast cells are far less likely to spontaneously calm down.
But the medical research doesn't stop with that grim prognosis. The final section of the NEJM paper points toward the horizon, and the clinical trials currently underway offer some incredible new pathways for that stubborn subset of patients whose bodies just refuse to stand down.
The pipeline for new therapies is thrilling for immunologists. We are moving beyond just targeting IgE. Researchers are currently investigating a class of drugs called anti-interleukin therapies, specifically targeting interleukin 4, 13, and 5.
Let's translate that. What are interleukins and why are we targeting them?
Interleukins are the chemical messengers that immune cells use to communicate with one another. While histamine causes the immediate flare, interleukins, particularly interleukin 5, are responsible for recruiting other heavy-hitting immune cells, like eosinophils, into the skin tissue to perpetuate long-term inflammation.
So it's communication.
Exactly. By introducing biologics that specifically intercept and neutralize these messenger chemicals, we hope to sever the communication lines, preventing the immune system from organizing the sustained attack.
And the paper also specifically highlights BTK inhibitors. What is the mechanism there?
BTK stands for Bruton's tyrosine kinase. It is a critical enzyme located inside the mast cell. If we return to our analogy, imagine the mast cell is a landmine. The IgE molecule sitting on the surface is the tripwire. But simply tripping the wire doesn't make the mine explode. The tripwire has to send an electrical signal down into the detonator.
And BTK is the wiring.
Exactly. BTK is the intracellular wiring that connects the surface receptor to the explosive payload of histamine granules. BTK inhibitors, which are small molecule drugs already successfully utilized in treating certain types of B-cell leukemia, are currently being studied in chronic urticaria. The goal is to see if we can chemically jam that firing pin. If we use a BTK inhibitor, we are essentially cutting the wire inside the landmine.
Wow.
You can trip the IgE wire all day long with autoantibodies or physical triggers, but the signal will never reach the detonator, and the mast cell will never degranulate.
That is an incredibly elegant approach. It feels like we are on the verge of not just managing the downstream symptoms of this condition, but truly mastering the intracellular mechanics that drive it.
We really are.
So let's bring this massive journey all together. We started with the simple image of a hive, a transient raised red bump on the surface of the skin. And by looking closely at it, we've uncovered a massive global epidemiological puzzle affecting tens of millions of people. We've seen how this seemingly simple skin condition carries a psychological and physical burden equivalent to facing major open-heart surgery.
Astounding.
We've explored the bizarre reality of mast cells that misfire so violently they attack the body for sweating or sitting in a chair or merely touching water. And we've seen how modern medicine has had to actively suppress the urge to run 1,000 blood tests, instead meticulously building a step care ladder to quietly disarm an overactive cellular security system.
It serves as a humbling testament to the incredible and sometimes terrifying complexity of the human immune system. We often think of our skin as just a static wrapper holding us together, but it is an intensely active, hypervigilant organ stationed at the frontier of the environment, fighting massive, invisible biochemical battles every single day. And when its calibration is even slightly altered, the impact on a human life is devastating.
Which brings me to a final lingering thought. The NEJM review mentioned that future research is heavily focused on investigating the exact autoantibodies and serum IgE levels to better predict the natural history and duration of the disease.
Yes, that's the next frontier.
And it makes you wonder, what if the key to understanding why the human body attacks itself in the modern era isn't hidden deep inside our internal organs? What if the earliest, most visible, readable clues to systemic autoimmune dysregulation are being broadcast directly on the surface of our skin? If researchers can eventually decode the exact structure of the autoantibodies that are causing these chronic hives, chronic urticaria might shift from being a frustrating, unpredictable clinical mystery.
They could change everything.
It could become the ultimate check engine light for our immune system. It could serve as the immunological Rosetta Stone that finally helps us unlock the cellular secrets of a dozen other devastating autoimmune diseases.
A fascinating and highly plausible prospect. It positions the skin not just as a barrier, but as the ultimate diagnostic canvas for the internal state of the body.
Think about the complexity of that cellular defense network the next time you look in the mirror. Thank you for joining us as we unpack the deep, hidden world of this incredible topic. We'll catch you on the next deep dive.